Good afternoon. Welcome to today's presentation, Neoplastic Pain, a new name for an old type of pain. This webinar is part of a series hosted by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded to the CMH YouTube channel for future reference. Please feel free to use the chat box to ask any questions and add comments you have at any time during this webinar. And if time allows, we'll answer as many questions as we can at the conclusion of our presentation. Our presenter today is Dr. Daniel Klaw. Dr. Klaw is a professor of anesthesiology, medicine, and psychiatry at the University of Michigan. He attended undergraduate and medical school at the University of Michigan, following which he did internal medicine residency and rheumatology fellowship at Georgetown University. While at Georgetown, he founded the Chronic Pain and Fatigue Research Center, and in 2002 was recruited to bring this group to the University of Michigan, where the group has become one of the most successful pain research groups in the world. And with that, I will turn it over to you, Dr. Klaw.
Thanks so much for having me. So I am going to talk about nociplastic pain today in the broader context of diagnosing and treating chronic pain. First, my disclosure slide. You see that I'm very anti-opioid. I've been testifying against the opioid manufacturers most recently. And obviously today I'm going to talk exclusively about non-opioid pain management strategies. So I'm clinically trained as a rheumatologist. I've become a pain researcher over time, but I always show this slide first because it just shows two individuals' knee x-rays. The one on the left has an entirely normal x-ray. The one on the right has advanced osteoarthritis of the knee where the cartilage is entirely lost and that person has bone rubbing against bone. And I show this because obviously I'm old, but I want to point out that when I was trained, I was taught that the person on the left would never have pain because they have an entirely normal x-ray. And the person on the right would always have pain because they have lost all their cartilage and they have bone rubbing against bone. It probably wouldn't surprise many of you to know that about 10% of people with an x-ray on the left will have pain. It wouldn't surprise you to know that some people that have a normal radiograph could have pain. But it probably is quite surprising if I were to tell you that about a third or more of the people that have an x-ray like the one on the right don't have any pain. And I'm showing knee radiographs today, but I could be showing x-rays or MRIs of any area of the body. And the reason I show this slide is to point out that you can't see pain on an x-ray, and that we know that in every chronic pain condition, there's actually a terrible relationship between what you see on an x-ray or an MRI, i.e. what's going on out in the periphery, and whether that person's experiencing pain and how severe that pain is. So why is that? Why is there such a tremendous disparity between what we can visualize on an x-ray or an MRI with respect to something wrong in the peripheral tissues and the presence and severity of pain? First, again, this is my 30 or so year career, where at the beginning of my career in the 90s, we still thought that osteoarthritis was the classic peripheral pain syndrome, and that we could, by looking at x-rays, tell who had pain and how severe that it was going to be. And then studies began to appear in the literature in the 1990s, showing this terrible relationship really between what you see on an x-ray and whether someone has pain or not. After these studies were done in osteoarthritis and in other chronic pain conditions where this was found, when people saw that there was a group of patients that had pain that didn't have anything wrong with their x-rays, the first thing they concluded is that these people must be crazy. They must have prominent psychological factors that are explaining their pain because we can't see anything wrong on their x-rays. And at the end of this slide, I just point out that in the condition osteoarthritis, not only did we get everything wrong about what's going on in the knee joint, for example, not explaining the entirety of what someone with osteoarthritis, the knee, experiences, but we overestimated the effectiveness of a lot of our therapies. Therapies like non-steroidal anti-inflammatory drugs in point of fact, only work well in about 1 out of 3 people with osteoarthritis of the knee or with any type of chronic pain. Similarly, the drug acetaminophen, we used to have this be the basis for a lot of the sort of the base of the pyramid for a lot of pain management strategies, but the more recent studies have suggested acetaminophen isn't really a very good analgesic at all and really has a very modest at best effect size. I'm not going to talk a lot about opioids, but if you look at the latest meta-analyses or Cochrane reviews, they basically come right out and say opioids should never be used to treat osteoarthritis because they simply don't work. And I'll show you some slides in a few minutes of studies that we've done where we've used arthroplasty or joint replacement surgery as a model. And we have looked at the 20 or 30% of people who have knee osteoarthritis have a shiny new titanium joint put in, and that doesn't at all help their pain. But we've used that as a model to help explain or understand why, if we just look at what's going on in the X-ray, we're only really seeing a part of that person's pain. And so the other condition that I'm going to talk about today, more as a metaphor rather than as a standalone diagnosis, is fibromyalgia. Our group at the University of Michigan is arguably the best known group in the world with respect to our studies of fibromyalgia, and we have helped legitimize fibromyalgia as a legitimate pain condition. There were a lot of things wrong about the early versions of fibromyalgia, that you had to count how many tender points people had, but a more contemporary view of fibromyalgia that I'm going to talk about today is that it's really sort of the poster child for a new mechanism of pain that we didn't really understand until the last 10 to 15 years. That's called nociplastic pain. And what we mean by nociplastic pain, it's a term that doesn't really have a lot of clinical meaning, but what these conditions have as their hallmark is the pain is very prominent part of these conditions, but people have a number of other symptoms like sleep problems, fatigue, memory problems. And what we know about this kind of pain is it seems to be coming from the central nervous system or the brain or spinal cord rather than from the periphery. And so I'm going to talk about nociplastic pain. This used to be called things like central sensitization or centralized pain, and how it's really revolutionized how we think about diagnosing and treating chronic pain. And it's given us a lot of opportunities, if you will, especially to more aggressively use non-drug treatments in managing pain, because the other big advent over the course of my 30-year career in the pain field, besides the legitimization of this mechanism of pain, where fibromyalgia would be the poster child, is how effective some of the non-pharmacologic therapies can be for managing pain, and how we really should be using an integrative approach and trying to give individuals with chronic pain access to a number of these therapies that we used to be dismissive of, things like acupuncture, yoga, tai chi, meditation, in addition to things like cognitive behavioral therapy, exercise, and a number of other things that I'll talk about, are now the mainstay of our treatment of chronic pain. And none of the medications work very well at all, but certainly opioid use should be entirely eliminated or only used when everything else has failed to work. One of the analogies that I started using about 10 or 15 years ago when I was explaining this kind of pain to patients was that the amount of pain that someone is experiencing is very analogous to the loudness of an electric guitar. And if I superimpose those two knees that I showed you earlier, the information coming from an electric guitar has to go through an amplifier. And you know that you can make the sound from an electric guitar louder either by strumming the strings of an electric guitar harder or by turning up the amplifier. And so now when I show these two knees again, this information from the knee is picked up by sensory nerves. And those sensory nerves then go up through the spinal cord and into the brain. But the spinal cord and the brain serve as the amplifier for pain processing and sensory processing. And we know that there are some individuals who are born with a higher amplifier setting. And by virtue of this, these individuals that have a higher amplifier setting are going to feel more of what's going on in different areas of their body. And some individuals' amplifier settings are so high in conditions like fibromyalgia that people can have pain in virtually any area of their body, even though there's nothing wrong with that area of the body, because the fundamental problem is with their amplifier, not out in the guitar. The other reason I like using this analogy of the guitar and the amplifier is it forces people to start to think of the fact that when they see someone with chronic pain, the pain can either be due to a guitar problem or an amplifier problem, but in most cases, it's a combination of both. And what we often see in people with chronic pain is they sometimes have a little bit wrong out in the periphery, out in the knee, but that's superimposed on the fact that they do have a very high amplifier setting. And therapeutically, this is an opportunity rather than a problem, because a lot of individuals have tried to manage their own pain, or providers have tried to manage the pain entirely with therapies that are working out in the knee by giving injections or surgery or using drugs that are going to work out here. But a lot of our therapies that work quite well for chronic pain are more so working more on the amplifier. They're trying to turn down the volume control in the brain and the spinal cord with respect to pain processing. And this is especially helpful for these nociplastic pain conditions like fibromyalgia, where this is the fundamental problem, or the only problem is an amplifier problem. And there's really nothing wrong, if you will, out in the periphery or out in the guitar. And so this slide shows the three mechanisms of pain, with the one on the right being newly recognized nociplastic pain. We've known forever that people can have nociceptive pain. That's pain due to inflammation or damage. If you bang your thumb with a hammer or you have a surgical procedure, there's nociceptive input, there's damage or inflammation. And that type of pain is called nociceptive pain. NSAIDs, injections, surgery work well for that kind of pain. And classic examples of that kind of pain would be osteoarthritis, something like rheumatoid arthritis or lupus, an autoimmune disorder, cancer pain. But there's something wrong out in the periphery that's causing that individual's pain. The second pain mechanism that we've known about forever is neuropathic pain, where the problem is out in the nerves. This can be things like carpal tunnel syndrome, sciatica, painful neuropathy from diabetes or alcohol. This is called neuropathic pain. But the International Group of Pain Researchers formally voted about 3 or 4 years ago and officially recognized this third mechanism of pain, where the pain was coming more so from the brain or the central nervous system. And I'm going to talk a lot about how you can differentiate these three types of pain. And I'll focus really more on some of these things because we know especially how to identify nociplastic pain. The pain is going to be much more widespread. These individuals with nociplastic pain will probably have had pain in multiple body regions in different areas of the body at different points in time over the course of their life. And they're going to have a lot of other CNS symptoms. They're going to have fatigue, memory problems, mood disturbances that are really core to this kind of pain. They're not a peripheral problem. And then the other thing that these individuals will have, if you do a really good history with these individuals, is that they will be sensitive to other types of sensory stimuli other than pain. Because again, the fundamental problem in these individuals is an amplifier problem. And brain regions like the insula that are hyperactive in people with conditions like fibromyalgia or irritable bowel or headache, these nociplastic pain conditions, these brain regions like the insula, when someone has a high amplifier setting for pain, they typically also have a high amplifier setting for any sensory information. So individuals with this kind of pain, if you ask them, are you bothered by the brightness of lights, the loudness of noises? Are you bothered by odors? Do you have a lot of side effects of drugs? Those will be other symptoms that these individuals with this type of pain will endorse, because literally their amplifier is not just set too high for pain processing, it's set too high for any type of sensory processing, whether that's painful information coming in from the periphery or whether that's the brightness of a light coming in through their eyes. Classic nociplastic pain conditions would be fibromyalgia, irritable bowel, temporomandibular joint disorder, tension and migraine headache, interstitial cystitis. I'll talk about these conditions, but these are some of the most common chronic pain conditions in humans. And in fact, this third mechanism of pain is almost certainly more common statistically just because of how many people have things like headache and fibromyalgia and irritable bowel. This kind of pain is actually more prevalent than this kind of pain or this kind of pain. So nociplastic pain, this is an article that came out last year in the journal Lancet where we talked about this. And again, you see that there's agreement that it's not just pain, it's pain plus fatigue, sleep, memory, and mood problems. And you also see that these individuals have a problem with sensory processing, not just pain processing, in that, again, it seems as though one of the primary problems is that the amplifier in the brain is set too high for any type of sensory information. Another new term that was introduced in the last couple of years is chronic overlapping pain conditions. And this was actually coined by the program officers at the National Institutes of Health because they were funding research in all of these different common pain conditions like headache and fibromyalgia, irritable bowel, interstitial cystitis, low back pain, endometriosis, and seeing that in almost all of these pain conditions, the mechanism that's front and center is nociplastic pain. And these labels, come to find out, are just labels that have been used historically to affix to individuals that have pain in their back or have pain in their pelvis or have pain in their vulvar region, but we don't really understand what the pain is due to. So we have these different labels that have developed historically. When we can't understand the pain, we just say it's low back pain. But now we know that the majority of low back pain is actually nociplastic pain or central sensitization rather than a problem in the back or again, obviously some individuals with low back pain have neuropathic pain, things like sciatica, but statistically, probably 50–60% of low back pain in the United States is really more nociplastic pain, fibromyalgia-like pain, than it is a problem in the back. These conditions in and of themselves are quite common, and these conditions alone would account for nociplastic pain being the most common type of pain. But the other thing that happens commonly is nociplastic pain or fibromyalgia-like pain very often accompanies nociceptive pain or neuropathic pain. So we know, for example, that a third of patients with cancer or a third of patients with autoimmune disorders like rheumatoid arthritis or lupus, or half of patients with sickle cell disease, that as they have pain longer and longer, a lot of their pain becomes more brain pain and nociplastic pain than it is from the periphery. And you have to shift over and use the types of treatments that work more so in the brain to treat that pain when that occurs, rather than thinking that those individuals are going to continue to respond to non-steroidals and injections and surgical procedures, which are really aimed at reducing the pain that's occurring because of ongoing peripheral nociceptive input. You also don't have to do a tender point count anymore. If you're trying to identify whether someone has this kind of pain, these are the new criteria for diagnosing fibromyalgia. You just give people this checklist. On the left, we're looking at how widespread the pain is, because how widespread the pain is, the number of different regions of the body that someone has pain in is one of the best measures of whether the pain's coming from the brain rather than coming from the periphery. And going back to my analogy, it would make sense to you if you turn up the amplifier, if you then strum any of the strings of the guitar, they're going to be louder. And that's essentially what we see in individuals that have nociplastic pain. You'll see that they check pain in a number of different body regions. And again, the more body regions they check, the more confident or comfortable you can be that it's likely to be that this is an amplifier problem rather than a guitar problem. And then they go over here and they are asked whether they have fatigue, memory problems, or sleep disturbances. And then they rate that as either not being present, slight, moderate, or severe. And this is actually scored 0 to 3 each. These symptoms here are scored 0 to 3 each. Each of these check boxes is 1 point. There's 19 check boxes. So you get 19 points on this fibromyalgia measure, depending on how many boxes are checked, a total of 9 points if you were to have severe fatigue, memory problems, and sleep disturbances. And then these symptoms down here only count for 1 point each: irritable bowel, depression, and headache. But there's a total of 31 possible points on this fibromyalgia measure. And if someone scores 13 or higher, these are now the new diagnostic criteria for fibromyalgia, just having people fill out that form. Having said that, I don't want you to use this measure in that way, because everything we've learned about fibromyalgia is you shouldn't think of either fibromyalgia or nociplastic pain as either being present or absent. You should think of that all of us have sort of differing degrees of fibromyalgia or differing degrees of nociplastic pain. All of us, if we're extremely stressed and sleep deprived and we haven't gotten any exercise recently, we'll get a little bit of fibromyalgia. We'll get a little achy. We'll be tired. We'll have sleep problems. And individuals, if you will, fibromyalgia-ness or level of fibromyalgia will vary over the course of their lifetime based on different things that are going on in their lives. And so it's really a lot more useful to think of this as the severity of nociplastic pain or the degree of this that someone has, rather than being present or absent. Because a lot of the individuals with fibromyalgia-like pain that might really benefit from, if you will, maybe a different approach to their pain that's been used historically, may not quite meet criteria for fibromyalgia, but they score 8 or 9 or 10 or 11 on that measure instead of 13. And these are individuals that might really respond well to some of the non-pharmacologic therapies or some of the non-opioid analgesics that might be, again, aimed more so at turning down the volume control in the amplifier rather than drugs that are working out at the periphery as either anti-inflammatory drugs or opioids. So again, I would prefer that you think of fibromyalgia rather than being yes or no, that different people have different degrees of fibromyalgia, because everything that we've learned about this really supports this. And I'll show you some data in a moment that supports this. So imagine that you're seeing either a patient or a client, and they're complaining to you of knee pain. Well, the first thing we would do is ask the person to fill out a body map, because a body map tells us a tremendous amount about the pain. And someone that has pain in a single knee is entirely different than someone who has knee pain that has this body map. This is someone with mad dog fibromyalgia, pain everywhere. When you see this, you don't have to wonder whether this is fibromyalgia or not. But again, this is someone with multifocal pain in a number of different areas. And they even will tell you that these different pain conditions occurred at different points in time over the course of their lifetime. Often this kind of pain will start right in adolescence, and especially after girls go through puberty and become women. That's when pain, any kind of pain, becomes 1.5 to 2 times more common in women than in men. And one of the biggest reasons, and perhaps the sole reason, that almost all chronic pain conditions are 1.5 to 2 times more common in women than in men is women are more pain sensitive and sensory sensitive in their brain, in the amplifier, not out in the guitar. And so this is why a lot of these pain conditions like fibromyalgia do occur a lot more common in women than in men, because women just innately start with a higher amplifier setting. And if it wasn't annoying enough to be a female in this regard, women that are actively menstruating, their pain sensitivity and their sensory sensitivity will typically go up in the premenstrual phase of their cycle. And again, we don't entirely understand why that occurs, but it's not controversial at all that women have a lot more chronic pain than men, regardless of what that chronic pain syndrome is. And so one of the problems that we face right now is that these people, some people have been diagnosed with fibromyalgia, but most people that have nociplastic pain haven't yet been called out or diagnosed as having a fundamentally different type of pain. They sort of are beneath the tip of the iceberg. And again, I used to show this slide as more of a problem, is that if you're not careful, and if you don't give every chronic pain patient the fibromyalgia measure to see where they are on this continuum, you don't know when you're going to like run into the iceberg and be the Titanic, and you as the provider sink because you're giving someone a therapy that isn't matching with the type of pain they have. But in the last 5 to 10 years, I've tried to be more glass half full and present it more as an opportunity. Is that if you start reapproaching people with chronic pain, give them that fibromyalgia measure, and you see that they score fairly high on it, and you say, oh, maybe a lot of their pain is coming from their brain rather than from the periphery, this is an opportunity, because a lot of the non-pharmacologic therapies are going to work better in this kind of pain. And it's also an opportunity to think about using different classes of drugs, non-opioid drugs that might be helpful. Drugs, for example, like serotonin or norepinephrine reuptake inhibitors like duloxetine can be extremely helpful to treat this kind of pain. The old term for what I'm talking about was central sensitization, and the new term is nociplastic pain. Again, I like the old term better because I think the term central sensitization at least gave people an idea that this was coming from the central nervous system, but no one asked us before they affixed this name to fibromyalgia pain. And so we have to live with nociplastic pain. And so anytime I give a talk, I'll say nociplastic pain / central sensitization or centralized pain, just so people understand what we're talking about. And I'm just going to briefly show you these studies that we've done recently at the University of Michigan that have helped the broader international group of pain researchers realize that this is a real type of pain that needs to be taken seriously. Our group does get a lot of funding from the National Institutes of Health to do research in 10 or 15 different chronic pain conditions. And this is a huge problem in any chronic pain condition, nociplastic pain. These particular studies I'm going to show you right now are showing that we can identify that subset of people with osteoarthritis, the condition that we used to think was entirely a peripheral problem. But about 30 or 40% of people with osteoarthritis, even though there is something wrong in their knee, they superimposed upon that, they have fibromyalgia-like pain. And if you do surgery on these individuals to try to treat their osteoarthritis, it's not going to work because the problem is in their brain and you're operating in their knee. The other thing about this kind of pain, though, is this kind of pain is very opioid non-responsive, even acute pain. So if someone, for example, with osteoarthritis of the knee, you give them that fibromyalgia measure and they score high on it, they're also not going to respond well to an opioid, even when that opioid is given right after the knee replacement surgery to try to treat the pain from the acute surgical procedure. So in these studies that I'm going to show you, basically on the day of surgery, when people were about to get either knee or hip replacement surgery for osteoarthritis, we had them fill out this fibromyalgia measure that I showed you earlier, but we had them fill out a number of other self-report measures. We didn't just look at this measure, but what was unique about these studies that I'm going to show you now is that we, on the day of surgery, had people fill out this measure, and we hypothesized that the higher they scored on this measure, the less well they would do with respect to that surgery making their knee or their hip pain better, and the more opioids they would need to control their pain. Again, this is how it's scored. You get 19 points for how widespread the pain is and 12 points for the symptoms on the right. But what we found in these studies was each 1 point increase in the fibromyalgia measure in these people getting knee or hip replacement surgery led to about 1 more hydrocodone needed to treat their pain in the first 24 to 48 hours while they were still an inpatient. So I'm just talking now about the opioids that were needed in the immediate inpatient stay right after their surgery. Each 1 point increase in that fibromyalgia measure made them 25% less likely to respond to that surgery. And these phenomena were linear. Going back to what I was saying, don't think of fibromyalgia as being yes or no. The higher the fibromyalgia score, the less likely people were to respond to that knee or hip replacement surgery with an improvement in pain. And the higher their fibromyalgia score, the more opioids they needed in the first 24 to 48 hours after the surgery to control their pain. Because again, when someone has this kind of pain, we actually think that the body's own internal or endogenous opioid system is participating in causing this kind of pain. So giving these people an opioid is a particularly bad idea. And this phenomena, how strong this the effect of this fibromyalgia score being predictive of surgery and opioid non-responsiveness was much stronger than anxiety, depression, catastrophizing, anything else that we measured here. This really was an incredibly strong effect, even though, again, a lot of clinicians don't pick up at this at all. And even our surgeons were doing surgery on a lot of people with really high fibromyalgia scores that we could see. And this is from the actual data from this study, is on the bottom here on the x-axis are the fibromyalgia scores. And you can see here, the red line is 13, that about 9% of the people that had joint replacement surgery while we were doing this study, there were about 700 people in this study, about 9% or about 55 of them had fibromyalgia on the day of surgery. We gave them the measure, and we saw that when they filled out that measure that I showed you, they met diagnostic criteria for fibromyalgia. And not surprisingly, they did really poorly when they had surgery. But people over here did really poorly as well. People who had fibromyalgia scores of 8, 9, 10, 11. And just to point this out, here's two patients here. Patient A gets his hip replaced. He has pain just in the hip that's hurting, and he has a tiny little bit of fatigue. That gets him a fibromyalgia score of 2. This person has pain in 3 or 4 other body sites, has a little bit more sleep problems, a little more fatigue, a little bit of memory problems. That gets him a fibromyalgia score of 11. But look at how different, even though this person doesn't have fibromyalgia, he hasn't crossed over the line to having 13 or greater. Look at how different patient B and patient A are when they have surgery. Patient B needs 90 milligrams more of oral morphine equivalents to control his pain just in the first 24 to 48 hours. That's a huge difference. And patient B, this person is 5 times less likely to get better if we send him or her to the orthopedic surgeon to get their hip or their knee replaced than this person, just based on what their fibromyalgia score was. Because again, the fibromyalgia score seems to be a really good measure of sort of what is that person's amplifier setting. And if their amplifier setting is really high, you should be therapeutically attacking the amplifier, not the guitar. What we did, and this is nice when you're a researcher, we exactly replicated these results in an entirely different group of people. These are women with chronic pelvic pain. Most of these women were diagnosed as having endometriosis. They had chronic pelvic pain. They were getting a hysterectomy in an attempt to relieve their chronic pelvic pain. And we found the identical features. In a different article, we found that each 1-point increase in the fibromyalgia measure led to the same amount of opioid non-responsiveness. And then here in this particular study that was published last year, each 1-point increase in the fibromyalgia measure in women with chronic pelvic pain getting a hysterectomy led to a 27% instead of 25% increased risk of not responding to surgery. So again, in 2 entirely different types of pain, this same measure was equally predictive of surgery and opioid non-responsiveness. I'm just going to skip this slide because it's not very relevant here. But we know that this fibromyalgia phenotype, this nociplastic pain, is very heritable, that a lot of people are sort of born with, and we know in family studies that things like fibromyalgia and irritable bowel and headache and things like that run strongly in families. And these are the individuals that have these chronic overlapping pain conditions are the ones that they themselves and their family members seem to have these high rates of fibromyalgia-like or nociplastic pain, this kind of pain over here. And again, this is not just of academic interest. When you see that someone's pain is this kind of pain rather than this kind of pain, you're going to have to shift over to using more CNS acting drugs, duloxetine, gabapentinoids, and then you're going to have to more aggressively use integrative therapies or non-pharmacologic therapies. But again, a point of emphasis again is that we know that 30% of patients with osteoarthritis or rheumatoid arthritis or cancer also have this kind of pain. And a lot of people with fibromyalgia have a little bit of osteoarthritis or a little bit of carpal tunnel. So that's another big way in which we've changed our thinking about chronic pain. We used to think that if you had just had the person's diagnosis, you knew they had osteoarthritis, that all osteoarthritis pain was this kind of pain. So this is the therapy we use for all osteoarthritis patients. And I just showed you that although surgery works well in a subset of osteoarthritis, it works decidedly unwell in the subset of osteoarthritis patients who have a lot of this kind of pain over here. Again, in these individuals that have osteoarthritis that have a high score in that fibromyalgia measure, we would put them in an exercise program, give them cognitive behavioral therapy, do any number of integrative therapies before we send them to surgery, because that would be a much more effective way in general of treating that kind of pain. Drug duloxetine, which is a drug that now is off patent, and we didn't know this when the drug was first approved for use in neuropathic pain and fibromyalgia. And most people are unaware of the fact that before duloxetine went off patent, it was actually approved by the FDA for use in low back pain and in osteoarthritis. But at the time that it was approved, we didn't really know what subset of low back pain patients it would work best in. And this study and other studies done recently in osteoarthritis show now that if you are using the drug duloxetine in a condition like osteoarthritis and you give someone just the body map alone, not the entire fibromyalgia measure, but the body map that was on the left side of that diagram that I've showed you over and over again, the more sites of pain someone has, the more likely duloxetine is going to work. And if someone has 5 or more sites of pain on that body map, duloxetine is 60% more likely to work for low back pain than if someone had low back pain and they only had a single site of pain in their low back. Similar article just came out in osteoarthritis as well that showed that when osteoarthritis is associated with more widespread pain, drugs like duloxetine are going to work a lot better, again, as are a number of these non-pharmacologic and integrative therapies. Our group gets a lot of NIH funding by doing things like functional brain imaging, quantitative sensory testing, all these cool things that you can do to really infer why or where the pain is coming from in individuals. And we can see on things like functional brain imaging, this is the first functional MRI study done in fibromyalgia. It was done by our group and it was published in 2002. But this single study really helped convince the Food and Drug Administration that fibromyalgia was a real disease. And it was only because that it was only in the late 1990s that functional MRI became available. So we didn't really have tools like functional imaging to peer into the brain of living awake individuals until the advent of things like functional MRI. And so it's not accidental or a surprise that the legitimization of conditions like fibromyalgia couldn't occur until scientific techniques like functional imaging allowed us to really say some of the things that I've been saying to you. And in this study, this first study in fibromyalgia, all we showed is that when you give fibromyalgia patients a low intensity stimulus to their thumb, a 2.5 kilogram stimulus, healthy controls say that that feels like a 2 out of 20, they barely feel it. But if you give that same amount of pressure to the thumb to a fibromyalgia patient, they'll say it's a 12 out of 20 on a pain scale, on 20-point pain scale. And when we put the people in the fMRI scanner, these fibromyalgia patients that were only getting 2 kilograms of stimulus to their thumb, we could see that the primary and secondary somatosensory cortices were lighting up in their brain, even though we were only giving that light pressure. That light pressure didn't cause those brain areas that we know are involved in pain processing to light up in the healthy controls. We had to give them twice as much pressure to cause the same amount of pain. But this first, and in fact, we did 3 or 4 initial fMRI studies in fibromyalgia. What they first showed is that these people weren't faking, that we could actually see on functional MRI that they were experiencing pain, even though the amount of heat or pressure that we were applying to them was not enough to cause pain in someone that didn't have fibromyalgia or didn't have a high volume control setting. More recent studies that we and others have done look at the brain regions that are either too connected to each other or not connected enough to each other. This is called functional connectivity. Even the size and the shape of the brain changes in these different chronic pain conditions as people have this kind of pain. And this is a study that we recently published showing that in children that are healthy, this is a very large study that's ongoing in the United States right now called the ABCD study. It's a study that is being funded by the National Institutes of Mental Health, primarily to look at the pathogenesis of a number of different mental health disorders. But there was just enough information in this study about pain for us to begin to mine the ABCD study and do pain research. Now, there's more and more information on pain, and we have NIH funding to do this, but this first analysis of the ABCD data showed that in children at age 10, that when they were put in the study, the 6,000 or so children that are being put in the ABCD study, they have to be entirely healthy at age 10, and then they're followed until they're age 18. And every 2 years, they get functional brain imaging, and every 6 months, they get a number of different questionnaires. And what we found is that in the kids who were healthy at age 10, but 2 years later had pain in 3 different locations of their body, that when we looked at those kids' fMRIs, that they had some of the brain changes that we see in adults with fibromyalgia at age 10 while they were still symptom-free, while they were still quote unquote healthy. So we can actually start to with something like functional brain image kids and see the children who are on their way to developing fibromyalgia-like conditions, because we can see that their amplifiers are set too high, that they have hyperconnectivity between some of these brain regions. And in a future state, what we'll do is do a lot better job of identifying these people that develop fibromyalgia-like pain conditions while they're adolescents, rather than ignoring those and saying this is a benign pain condition that a child or an adolescent gets right now, because these adolescents that develop fibromyalgia, irritable bowel, growing pains, functional abdominal pain are the ones that become the fibromyalgia low back pain patients that, again, once people have had this for so long, it's a lot more difficult to treat. And even the size and the shape of the brain changes over time in these nociplastic pain states. And we think this is because of neuroplasticity. This is a study we were involved in looking at chronic pelvic pain or interstitial cystitis. Big network. This is a couple slides summarizing 20 or 30 different studies that have been published. But the biggest finding that we found in this big network of individuals that are diagnosed with the condition interstitial cystitis is only about 15 or 20% of the interstitial cystitis patients only had pain in their bladder region. About 20% had pain in their bladder plus pain in their abdomen pelvic region, and about 50 or 60% had a more widespread pain phenotype like fibromyalgia. And as the network went on, this is what made all the difference in the world. These individuals with pain confined to their pelvis actually respond well to things like physical therapy directed to the pelvic floor, whereas these individuals with widespread pain, even though the label is interstitial cystitis, once you see on a body map they have widespread pain, then what they responded best to were things like drugs like duloxetine or gabapentinoids or other treatments that are more centrally acting rather than peripherally acting. And on functional brain imaging, what we found is that these individuals with interstitial cystitis that was confined to the pelvis looked like healthy controls on functional brain imaging, but the individuals with interstitial cystitis that had widespread pain looked actually on functional brain imaging almost identical to fibromyalgia patients. Even though their label was interstitial cystitis, their brains look like fibromyalgia, and they really should be considered more nociplastic pain fibromyalgia with respect to how we treat them and what's going to work from a treatment standpoint. This is another study from another group just showing it's not just our group that does this, and this with less than 40 patients and 40 controls used functional brain imaging to show that they could tell with over 90% sensitivity and specificity the fibromyalgia patients from the controls. So if you went into this talk thinking there's no organic basis for conditions like fibromyalgia, there's no biological basis, that's just not true at all. Those of us that do these studies and follow the literature, there's quite reproducible things that we can identify in the brains using things like functional MRI or functional connectivity. The problem is that these tools are not yet available clinically, so you can't order any of these clinically, and thus these individuals with these pain conditions are still stigmatized because a lot of people don't believe their pain is real. This is a series of studies done by Yvonne Lee showing that there's a big subset of people with rheumatoid arthritis or lupus, any autoimmune disease, that even after we treat them with these really effective drugs, these biologics that have been developed, that a lot of these people don't really get much better, and it's because they have central sensitization or nociplastic pain, and we can actually see that in the brain. So the reason this is all important is you have to move over. These are the treatments, the drug treatments that work for this kind of pain: tricyclic drugs, serotonin norepinephrine reuptake inhibitors, gabapentinoids. And then these might be somewhat helpful, but notice here we're using low dose naltrexone. We're actually trying to block the endogenous opioid system. And cannabinoids might be helpful for these patients, with the operative word being a very little amount of THC seems to be a lot better for pain than the amount of THC that people are typically using. If they are in the state of Michigan, they try to use cannabis to treat their pain. They often take way too much THC and they get high rather than pain relief, because what we now know is that there's a U-shaped curve, and that a low amount of THC works better to treat pain than a high amount. But again, these are the drugs that we should be preferentially using in this kind of pain. We actually know that from a lot of different studies why these drugs only work in about 1 out of 3 people, because different people have different neurotransmitter abnormalities that lead to this final common pathway of a hyperactivity of their sensory nervous system. This is an editorial that I wrote a couple of years ago talking about all the problems with giving people opioids chronically, because we can't, it's not just that they don't work, it's that we can't get them off of them because they become dependent on the opioid. And one of the analogies I used in this editorial is that if you put someone on opioids and you have they're on chronic opioid therapy, it's a lot like those of us who are trained as a rheumatologist when we put them on prednisone or put them on corticosteroids, that after people have been on those drugs for a long time, their body's own internal or endogenous hypothalamic pituitary adrenal axis doesn't work. And similarly, if people have been on opioids a long time, their endogenous opioid system doesn't work, and they feel terrible if they try to come off of the opioids. This is a study we did that showed that in fibromyalgia patients, it looks like the body's own internal opioid system is hyperactive, and that part of the pathogenesis of fibromyalgia is people produce too much endorphins and enkephalins, and those endorphins and enkephalins are acting in the brain to turn up the volume control. And this is why we're giving low dose naltrexone to actually block these opioids. You can see now why I'm so anti-opioid, especially with this kind of pain, is that there's a lot of evidence that we make a lot of chronic pain worse, not just not make it better, but make it worse by giving people an opioid. Because if you give someone with this kind of pain an opioid, we can see biologically why someone would get worse and worse and worse over time. We do a lot of work with cannabis now. We have a lot of NIH funding with cannabis. I give hour-long talks on cannabis. The short version of the talk is here, and that is that cannabidiol or CBD seems to be very safe, and people should be trying CBD alone before they add THC. Start at 5 to 10 milligrams a day, go as high as 100 to 150 milligrams a day. The main side effect of CBD is cost. It's fairly expensive. And then only if CBD alone is ineffective, then add a little bit of THC. But again, a little bit of THC goes a long way. And as you go up on the amount of THC, you get less pain relief rather than more pain relief. And so I'm going to end by talking about how important the non-pharmacologic therapies, the so-called integrative therapies, are. Because what happens in chronic pain patients is, regardless of whether their pain starts out in the knee or in the brain, as people have pain longer and longer, they develop stress, they become less active, they sleep poor, they gain weight, they develop bad habits. And so we've been using things like education, exercise, cognitive behavioral therapy for a long time. And by the way, many of us think that long haul syndrome has a lot to do with sort of fibromyalgia or nociplastic pain. That yet again is another talk at a different time. But the other thing that's changed dramatically in the last 30 years or so is how the evidence base for these non-pharmacologic therapies has changed in pain. And our terms have changed. We used to call these complementary and alternative therapies, and we can't call them alternative therapies when they're at least as effective as any of the drugs or any of the other things that we should be using. And so you see here like hypnosis, biofeedback, warm baths, yoga, Tai Chi, acupuncture, acupressure, massage therapy. These are things that I never would have imagined when I was trained 30 or so years ago we would have been advocating, but it's because the evidence base has gotten to the point that these things really all can be quite effective. And we spend a lot of time in our group developing websites and apps, and we have a really cool website now that I'd recommend you use with your patients or clients called Pain Guide. It's free. This is being used in a lot of ongoing NIH studies. But if you can send people to different parts of Pain Guide, and it gives them guidance about how they can themselves use some of these integrative therapies. It doesn't require them actually going to a provider. They can track their symptoms. But again, we develop these tools in our research group at the University of Michigan and hope people use them because they really can help with what you can do one-on-one working with your clients, help improve the overall management of pain. Even we're doing a lot of work now on diet and nutrition. We think that that caloric restriction or low calorie diets might be helpful, especially in people with these nociplastic pain conditions. And I like ending with this slide here. This is the VA and the DoD healthcare systems in the United States are the most forward thinking with respect to pain management. And look at all of the therapies that people now can get covered in the VA or DoD healthcare systems in the US if they have chronic pain. Tai Chi, yoga, mindfulness, chiropractic manipulation, acupuncture. And it's not, the reason for this is that the evidence base is such that these work and that we should be using them. So the challenge for the rest of us that don't practice in these systems is to figure out how we can surround our chronic pain patients with more and more of these integrative therapies. And again, similarly, sort of try to destigmatize individuals with fibromyalgia-like pain that haven't been believed over the years because we can't see their pain on an X-ray. Their pain is very real. We know their pain is very real. And now we're trying to move forward and identify more of those patients and treat them the way they should be treated. So I'll stop there and take any questions people might have. Thank you.
All righty. So there were a couple of questions in the chat. Some of them you've already answered in subsequent slides. Somebody asked about getting a copy of the PowerPoint. We will put that up on the website where you want to register for the session. So we'll make sure that is available to people. Someone early on in the presentation asked about, would you consider nociplastic pain something that happens to essentially highly sensitive people? I don't know if you want to kind of talk on that a little bit.
Yeah, I like, I have a joke that I forgot to tell, and that is, you know, for the women that when I said all of these things are a lot more common in women, if you do flip it around, you've known that males are insensitive forever, and now I'm just giving you the sort of biological evidence for that. But we really are learning that fundamental difference between men and women, which by the way, actually seems to be in women, it's much more likely to be an absence of testosterone rather than female sex hormones causing this difference. That's another shift in our thinking. But regardless, women are more sensitive to any kind of sensory stimuli. And I'm not talking about emotionally sensitive. I'm just talking about just how their brain works. And there might have been thousands of years ago, there might have been a reason that the female was supposed to be guarding the family. And there'd be an advantage to being more sensory sensitive to things around, whereas the male was going to go out and fight, and that again, you wouldn't want to be as sensitive. And we know that during activity or exercise, you become less painful because all those endorphins you release that's an adaptive thing, is that if you're fighting, you don't want to have pain. But again, what happens in these chronic pain conditions is these aren't acute adaptive responses. When someone has chronic pain, it's just miserable to be that sensory sensitive. There's nothing good about it, as far as I can tell.
Yeah, it's interesting how that evolutionary process still plays a role for folks. We have another question in the chat. Said, I saw a slide on vitamin D. Are there any other supplements that are recommended for nociplastic pain?
So vitamin D levels are low in almost everyone with chronic pain. And if you find that someone's vitamin D levels low, it's a good idea to replace it, but it probably isn't going to make their pain better, unfortunately. There's other supplements. Magnesium supplements seem to have a little bit of evidence in certain settings. But as you might imagine, that hasn't been as well studied as some other areas. And so a lot of the nutritional supplements that claim to be effective for chronic pain don't really have a evidence base. Coumarin is another one where there actually is an evidence base, especially when the pain is a little bit more inflammatory, like osteoarthritis. that's a nutritional supplement where there, is an evidence base.
So we have a lot of social workers, counselors, therapists, substance use treatment providers on our training here today. So when they're working with someone that they suspect might have this type of pain or be experiencing some of these symptoms, what are the like the first steps that they can take? How do they help that person maybe prepare for that conversation with a doctor, provider? What can they do if they suspect that someone is dealing with something like this?
Yeah, so this is a terrific group of providers because, I mean, they by and large are often using cognitive behavioral techniques to treat other kinds of things. And so this is in their wheelhouse, and they have, they know how to use some of these tools. But the first thing to do is validate, just like if you're dealing with a mental health disorder patient, is validate that patient's pain and say, yeah, I know, you do have fibromyalgia. Sometimes it's sad, but sometimes fibromyalgia patients say, like, one of the best days of their life was when someone finally said, we know what you have. Then they go to doctor after doctor and they're just dismissed as being neurotic, middle-aged, usually, again, women typically. But so first validate their pain and try to, and be empathetic and say, let's try some things. The other thing that I really think can be incredibly helpful, because a lot of people with chronic pain, they do try a couple things themselves and they don't work and they get in a rut. They just get in a rut where they don't. And one of the things I would really strongly recommend is show something like that very last slide that I showed, where you show acupuncture, Tai Chi, yoga, and you show all of these different therapies and you say, Mrs. Jones, all of these have been shown to be effective and you haven't really tried any of them. How about if in the next year we figure out how you can try 2 or 3 of these? Because we don't know which of them is going to work for you, but we do know statistically 1 out of 3 works in the trials. So statistically, if you try 3 of these therapies in the next year, the likelihood is that 1 or more of them is going to help you and you'll keep doing that. And so I think that's another thing that you can do with your clients and providers, is just sort of give them a nudge to try to start to give them hope that, maybe if they do try some things and they get off the couch and they start moving and they really try to get better, that these self-management techniques really can be helpful and effective. And certainly the people who are expert at things like CBT will say it's really important to give people small wins. One of my coolest small wins is if you have a chronic pain patient and they have fatigue, which almost all of them do, don't talk to them about doing exercise, because exercise is like, people with chronic pain, if you tell them to exercise, they'll look at you like you're stupid. But if you tell them that I want you to become more active, you won't get that look. And it turns out that you don't actually have to do Jane Fonda, Richard Simmons bouncing around exercise to actually get a benefit if you have chronic pain. You just have to become more active. If someone just gets up and walks for 5 minutes every couple hours. And the cool thing is, the symptom that's going to get better before pain is fatigue. Anyone that's been had like death by Zoom, like, if you do 6 hours of Zoom, everyone is tired after 6 hours of Zoom because you've been sitting still for 6 hours. And if you get up and walk around, you feel better. But use that with your chronic pain patients and get them to understand and realize the reason they're tired all the time is they're sitting all the time, and everyone's tired if they sit all the time. But there's really simple things you can do to get people off the couch, get them moving, and give them some early simple wins, and get them to believe that they actually can, with a website like Pain Guide and a case manager that comes every so often and says, did you try anything new, or you want to try something different? They can get a lot better without actually even ever setting foot in a healthcare system. We often, I say this to our trainees. There was a group of terrific articles published in Lancet on low back pain a couple of years ago, and my favorite article of this series was, it showed that in every country, if a person with chronic low back pain becomes a patient with chronic low back pain, the healthcare system is more likely to make their pain worse than better. In the US, we do that by doing too much surgery and too much injections, is that we do surgery that no other countries do because orthopedic surgeons and neurosurgeons make a lot of money, and patients don't want to be told you got to do yoga and Tai Chi and whatever. They want to get surgery so that cut out the problem and I don't want any pain. So there's a lot of people in the United States that get way too many injections and way too many surgical procedures for their pain. But in Kenya, where I actually spend time, they do the opposite. They do what we did 40 years ago when I was being trained at Georgetown as an internist. They actually put people with acute low back pain in the hospital in traction, and they immobilize them. And the studies published in the New England Journal 30 years ago, you know, we used to do that in the US until those studies showed that's like the worst thing you can do with someone with chronic pain is have them be inactive. They got to move. They have to start moving or their pain's never going to get better. But again, the point there was that going to a health system doesn't always or even often make pain better because we medicalize it. We send people down these different paths that often they need more just self-management, self-care kinds of things that if we made these things more available and accessible to them, they could sort of treat in place. They don't have to be going to a doctor every time they have pain.
That's excellent information. So my takeaway from that is that, you know, our staff here and the folks on this webinar are absolutely equipped to do some good work here with their clients. So that's excellent. Thank you so much.
I'd be happy to come back and talk about cannabinoids, talk more about pain management. Again, we're really passionate. We have a lot of faculty in our group that like to teach. So
yeah, we would love that. A lot of comments are saying this is great. We want more. So we'll definitely get in touch on that. So rest assured, everybody, we are hearing your comments loud and clear. So I just want to thank you, Dr. Clough, for your time and information today, and to everyone on our webinar for attending. Just to recap, our presentation is one of many webinars scheduled throughout the month of September. You can still register for upcoming presentations at sccmh.org. Thanks again for joining us today, and we look forward to seeing you all at the next one. And thank you, Dr. Clough.
Okay, thank you.